Good evening, fellow colleagues. Welcome to this symposium tonight organized by the Hong Kong Society for Infectious Disease. I'm Dr. Ada Lin, President of the Hong Kong Society of Infectious Disease. It gives me great pleasure to co-chair this evening symposium with Dr. Maggie Ma, President of the Hong Kong Society of Transplant Patients. Today, we have a very rich and very fruitful program tonight. We would have two very distinguished speakers, Professor Ivan Hong from Hong Kong, as well as Dr. Leung from Singapore, to share with us their insights on how to tackle COVID-19, especially on prevention of strategies to protect the immunocompromised populations. And then we will have panel discussions with other experts as well followed. So before I introduce our first speaker, may I pass to Dr. Maggie Ma to give us a few words.
Oh, good evening, everyone. It's my pleasure to welcome all of you in this online symposium, even in the Typhoon number 8 signal is hosted. And I hope today's meeting can provide us some inspiring information, and also we can have a fruitful discussion on the management of COVID-19 for our patient. And without further ado, may I invite Dr. Lin to introduce our first speaker. Thank you.
Our first speaker is Professor Ivan Hong. I think he needs really no introduction because everyone would know him very well. Professor Ivan Hong is currently the chief of the divisions of infectious disease of the Hong Kong University. He has contributed significantly in the local combat against COVID-19. He currently served the chief executive expert panel of the Hong Kong government, as well as being the convener of the vaccinations clinical assessment panel. So without further ado, please join me to welcome Professor Ivan Hong. Ivan, please.
Thank you, Ada, for the very, very kind introduction. And I would like to thank both Ada and Maggie for inviting me to talk about COVID management and prevention in this symposium. My talk will be very general on how to manage and how to prevent COVID-19, and I will leave the so-called prevention in terms of prophylaxis and vaccination in the immunocompromised to my very good friend Dr. Leong, Hoe Nam, who will be talking about more focus on how to protect the immunocompromised host. Okay, so this is my slides, and this is my disclosures. This is the latest situation as of the 1st of November, which was yesterday, according to the Johns Hopkins dashboard. That, of course, we have more than 630 million cases worldwide, more than 6.5 million people who've died from COVID, and, of course, more than 12 billion doses of vaccine has been given already. Of course, there's an inequality in terms of the vaccine distribution, and that, of course, many of these unfortunate in the developing countries, especially in Africa and perhaps in South America, there is a lack of vaccine given to these population, and most of the population have been infected with COVID. That, in a way, ironically, do protect, have given a pretty good protection in this cohort. In Hong Kong, this is the latest situation, and it's been fluctuating over the past few weeks in terms of the number of cases, from, of course, around 4,000 to around 6,000 cases a day. But in general, you see that it's probably on the downward trend for the past week or so. In terms of the importing cases, the numbers are again increasing in proportion due to the increase in decreasing in terms of the local number of cases. But I guess we will probably hover around 3,000 to 5,000 cases a day in the coming weeks or so. And this, of course, is because of the very robust hybrid immunity. That means that most of our population have been vaccinated with either 2 doses, of more than 92% have been 2 doses vaccinated, and more than 80% of the population have been 3 doses vaccinated. Despite, of course, the emergence of the various subvariants, including the BA.2.75.2, the BA.4.6, the XBB, XBD, which is subvariants from the BA.2, and the BF7, BQ1, all these subvariants from the BA.5. The overall, in terms of the both the number of new cases, the number of severe cases remain very static. That means that most of the cases are relatively mild or asymptomatic. Despite the overall deaths in Hong Kong have risen more than 10,000 for the past year, especially since the 5th wave, as we said. If you're just counting the mortality rate from the 1st of May to the 1st of November, that means in 6 months, is actually around 0.08%. That means that is actually lower than the seasonal influenza of 0.1%. And overall, we are seeing the overall pandemic is getting milder and milder, despite that there are subvariants emerging all the time. Situation in Singapore, very, very similar in Hong Kong, probably slightly like 3 or 4 weeks ahead of us. But again, you're seeing a fluctuating of number of cases, 6,000 to 12,000 a day. Of course, in Singapore, they now have basically relaxed most of the infection control measures, and that they are seeing a similar trend. And again, despite that, the number of hospitalization have risen over the last 2 weeks or so, it's been fluctuating around 600 to between 400 to 600 cases every day. ICU cases again is quite similar, but interesting is that you are seeing previously at the beginning of October, the non-fully vaccinated are the predominant ICU cases, but more recently is the fully vaccinated who are ending up in the ICU. And that probably is due to the weaning of the vaccine that has been given probably more than 6 months ago, especially in the elderlies. And that, of course, that with the emergence of the subvariants that probably have some degree of immune escape. And that explains the changes in terms of the fully vaccinated versus the non-vaccinated. But overall, predominantly, the majority of the cases of more than 99.7% are actually mild and asymptomatic cases. Very, very few, about 0.04% is in ICU and 0.03% ending up dying of COVID. And we are seeing similar trend in Hong Kong. Just looking at Queen Mary, we do not have a case in ICU for the past, I think, 2 weeks or more. So that is the trend that we are seeing. In terms of emergence of subvariants, again, you see that basically predominantly Omicron BA.5 in South Africa, that most of these subvariants or variants are emerging, and now we're seeing Omicron BA.2.75 emerging and BA.2.1, 2.1 starting emerging, which I guess by now would have been probably as an increasing proportion of these subvariants. Most important, as I've said many, many times, is the hybrid immunity. That is very robust for most of the community, probably apart from the mainland, that very few people have been infected. The hybrid immunity, in fact, is it provides the basic immunity. That means that you have been vaccinated and then infected, or vice versa, and thereby creating a very high so-called immunity or protection against the COVID-19. And that is different, of course, from herd immunity. The herd immunity is that majority have been vaccinated, protecting those who have not been vaccinated. But hybrid immunity is more, you have been both vaccinated and infected to have the so-called acquired immunity. And that, of course, in this study, if you have not been infected and you just have the booster, you have a pretty good rise in terms of the neutralizing antibody against the BA.4, BA.5 with the current vaccine. And then, of course, if you've been infected before a vaccination, then the antibody level is much higher, risen to about 600 neutralizing antibody titer against the BA.5. Similarly, in another study, that if you have basically recover, followed by a vaccination. That means there's a hybrid immunity, then the risk of acquiring the infection is much lower compared to one dose, and then you have the infection. And again, it's even lower compared to receiving 3 doses of the vaccine if you have a so-called like a vaccination plus infection. Before I talk about antiviral treatment, I have to go back to this slide, which I've used many, many times. Again, is the pathogenesis. And again, probably shortened in terms of the duration of viral carriage in Omicron to probably now about 5 days and 1 or 2 days of so-called incubation. And then, of course, followed by, again, a hyperinflammatory phase. And the reason why we want to give antiviral or vaccination is to suppress the viral load and thereby preventing the hyperinflammatory phase and the complication as a result. So treatment, the principle of antiviral treatment is based on a combination therapy. If you do not have a so-called focus or target antiviral. And of course, with the emergence of possible resistance, you probably still need a combination of antiviral treatment. And that will, of course, increase the spectrum of activity, potency, and reduce the risk of resistance. Mechanism, of course, there are different mechanisms for the trimavir, ritonavir is based on a protease inhibitors mechanism. And for the molnupiravir, remdesivir is based on the polymerase inhibitors mechanism. And for vaccines and also by the monoclonal antibody, it actually works by blocking the virus from attaching to the ACE2 receptors, thereby preventing the interaction of the virus entering into the whole cell. So this is, of course, one of the very, very early publications of the triple therapy when we do not have any antiviral but using the in vitro and in vivo data, we find that interferon beta 1b has a best so-called selective index against COVID-19, far better than remdesivir. And by using this combination as an early treatment, we're able to, of course, basically alleviate both the symptoms as well as the viral suppression in using the triple therapy against the control group, which just uses the loponavir, ritonavir. The caveat of the study, of course, is that we give the antiviral very early stage within 5 days from symptom onset to our patients. And similarly, another study that we use interferon beta 1b with remdesivir versus remdesivir alone, again, much better in terms of clinical alleviation and viral load suppression. And again, is given within 3 days from symptom onset in this elderly cohort. Molnupiravir, of course, has been widely used in Hong Kong and many parts of the world, especially in Hong Kong. And again, it's shown that if used within 5 days from symptom onset, is able to reduce the so-called hospitalization and also mortality by about 30% compared to placebo as an outpatient use. And similarly with matravir, ritonavir, if you use it within 3 days from symptom onset, it will lead to a much better outcome in terms of hospitalization and death by using it as an outpatient, reduction by close to 90% by using this combination versus placebo. Of course, there are some drawback on the matravir, ritonavir usage is the drug-drug interaction, and that is perhaps one of the reasons why in Hong Kong, especially initially, it's been more widely used in the so-called relatively younger, healthy patients compared to molnupiravir, which do not have the drug-drug interaction. And of course, there are quite a number of drugs that you should be aware of, especially in the post-transplant cohort who are using sacrolimus and tacrolimus that could not be stopped, and also many of the antiplatelet agents that could not be stopped, especially in those in post-PCI individuals. And of course, in our subcommittee from the hospital authority, we have been formulating this with Dr. Owen Zhang, this very simplified version of the matravir, ritonavir drug-drug interaction to help especially our geriatrician or our family physician in giving this drug to the elderly population. In terms of resistance, of course, in vitro, there have been some mutants identified in various reports. Nevertheless, in terms of clinical rebound or clinical resistance, we have not been finding these cases in our cohort, at least in Queen Mary Hospital. Nevertheless, we are expecting some resistance to emerge as more patients are being treated with this medication. And of course, we do have a HA interim guideline in using this oral antiviral drugs, plus, of course, other immunomodulators when given in lay presenters and patients who have presented with moderate, so-called to severe disease. Indication, of course, the two drugs very similar. Important, of course, is the drug-drug interaction. Of course, patients who have so-called Chelsea cirrhosis will be contraindicated for giving the nirmatrelvir-ritonavir. And for molnupiravir, there are no such drug-drug interaction. Both drugs can now be given via the nasogastric or the PEG tube. And then, of course, the nirmatrelvir-ritonavir could be given in both pregnant and lactating mother. And of course, if they have a slight renal impairment, you have to give the half dose to nirmatrelvir-ritonavir. This is, of course, very interesting real-world data concerning the two antiviral, a publication by our School of Public Health colleagues. And looking at this big data analysis, they first look at those hospitalized patients who's been given the molnupiravir and also the nirmatrelvir-ritonavir versus the control group, which is very well matched in terms of both the age, sex, and also in general the Charlson comorbidity. The viral load, of course, at the onset, again, admission had been quite similar in terms of the CT value. The study demonstrated very clearly that both drugs are able to suppress both reduce the number of all-cause mortality and, of course, other things, including both the so-called clinical progression, leading to a much better clinical alleviation, and also in terms of viral suppression and the need of intensive care and mechanical ventilation and oxygen therapy are both better in the antiviral group. And the difference start to show, especially more significant from day 14 onwards, in both the so-called molnupiravir and also the nirmatrelvir-ritonavir group. They performed a similar study in terms of the community-dwelled outpatient cohort. Again, very well matched in terms of the age and Charlson comorbidity. And then, of course, the all-cause mortality are much lower in the molnupiravir and also the nirmatrelvir-ritonavir group. The nirmatrelvir-ritonavir group, of course, the age-wise is slightly younger compared to the molnupiravir group because, of course, the doctors are slightly worried of the drug-drug interaction in the elderly cohort, and hence more are given the molnupiravir instead of the nirmatrelvir. In terms of hospitalization, there is probably a slightly so-called non-significance in the molnupiravir group, and again, just a slight reduction in terms of the nirmatrelvir-ritonavir. However, in terms of the hospital disease progression, are significantly better in the antiviral treatment group. Similarly, again, the significance starts to show from day 14 onwards in both antiviral group. Immunomodulators, again, very, very important in terms of the late presenters, in those who presented quite late and start showing some cytokine storm, especially in those who presented from a so-called beyond day 5 from symptom onset. And again, of course, dexamethasone is very important in controlling this cytokine storm. Other immunomodulators, including the baricitinib, and also the tocilizumab, which is the JAK2 inhibitors, and the interleukin-6 inhibitors, have been shown to be beneficial, especially if given in the second week from symptom onset. Chemoprophylaxis, very, very important. In this, of course, the tezepelumab, this combo monoclonal antibodies have been shown in this study that is able to reduce in terms of the so-called subsequent positive PCR positive symptom illness in this cohort who have been given this monoclonal antibody, a reduction by about 70% from a so-called developing a symptomatic illness by given this so-called monoclonal antibodies. And similarly, as an outpatient in this so-called TACO treatment trial, given within the double dose 600 milligrams in terms of instead of the 300 milligram dosage, again have been shown to work very well when compared to placebo in terms of patients who have been given this treatment as an outpatient, thereby reducing the so-called severity development in patients who acquired the COVID-19 infection. Important, of course, with the emergence of these Omicron subvariants, there are some so-called resistance start to show with the reduction in the IC50. If you look at the tezepelumab and sirgivimab on its own against the BA1 and the BA2, there is basically a much so-called resistant emergence against the BA1, BA2 in the tezepelumab, and again against the BA1 in the sirgivimab. However, if you give this as a combo, the so-called resistance could be overcome by this combo. More recent data from Japan look at the data against the BA2, BA5, and the BA2.75. The good news, of course, if you look at the oral antiviral, the so-called IC50 still remains pretty low for these remdesivir, molnupiravir, and also nirmatrelvir. There are, however, some emergence of resistance starts to show against the BA2 and perhaps against the BA2.75 with the so-called tezepelumab combination in this cohort. The new agent, the bebtelovimab, has remained so-called sensitive in this subvariants. So again, we will need, of course, some new monoclonal antibody in order to so-called remain getting things on top against these subvariants. Vaccines, quickly talk about vaccines. So, of course, more than 120 clinical trials on vaccines are now on trials, and some have been completed already and already been approved for use in emergency usage. And this, of course, are the various platforms, including the mRNA platform, the inactivated vaccine platform currently available in Hong Kong and also in Singapore. And of course, in other countries, they have been using some adenovirus vaccine platform, both inhaled, of course, in all the so-called injection formula and also the recombinant vaccine. Important to look at is the T-cell response, perhaps, in this so-called, in our study, there was from our microbiology department by Professor Chen Jiwei's group in e-biomedicine. So looking at both the T-cell response and also the anti-spike IgG, anti-receptor binding domain IgG, basically the mRNA vaccine fared better compared to the inactivated vaccine, both in the spike IgG, RBD IgG, and also in various kind of variants, also against the T-cell response. Nevertheless, both compared to the inactivated vaccine, nevertheless, both vaccines start to drop again about 180 days after vaccination. The drop, of course, is much more significant with the inactivated vaccine. And of course, those who have undergone organ transplantation, as shown in this slide from the CDC, basically are those who will have a very poor response in terms of neutralizing antibody titer. And these are the cohort that probably will beneficial from a booster dose, a more frequent booster dose, and probably even better by given the monoclonal antibodies in this post-transplant cohort. In our studies by my group and also by the School of Public Health together with the CUHK study, have been able to show, of course, if you give a hybrid vaccination with 3 doses of BioNTech or 2 doses of inactivated followed by a mRNA vaccine with BioNTech against the Omicron variants, it fares better than just receiving 3 doses of the inactivated vaccine or a combination of so-called BioNTech or mRNA followed by a inactivated vaccine. So-called the heterologous vaccination or a pure mRNA vaccine probably fare better in terms of antibody response against the Omicron. However, more important is to look at the clinical effectiveness by this study from our School of Public Health, against looking at the big data, suggesting that if you have received 3 doses of the vaccine, regardless whether it's mRNA or inactivated vaccine, it actually do very well for all age group, especially looking at the dose above the age of 80. You offer more than 97% in terms of clinical effectiveness for 3 doses against death and also against severe disease. However, if you start dropping to 2 doses, the inactivated vaccine actually do quite poorly, of lower than 60%, and mRNA vaccine drop below 90%. So the keys, but again, mild to moderate disease, both vaccines is not very well. The inactivated vaccine is about 32%, and mRNA vaccine about 7% for 3 doses. The reason for this, of course, is the very poor IgA immunity in the mucosa in the upper respiratory tract. So the vaccine platform, the key message is to receive 3 doses of the vaccine, regardless of what platform you are, and that will be able to protect you against severe disease and death. Nevertheless, the protection against acquiring infection and mild disease is relatively poor for both platforms, especially the inactivated vaccine. So important is to look for, of course, forward to the Omicron adapted vaccine, which of course the FDA has already approved the mRNA vaccine with the BA.5, even though they have just still ongoing phase 3 clinical trial. They currently probably just have the with the BioNTech just having the animal data. The Moderna is better, which they have completed the BA.1 and again ongoing BA.5 so-called bivalent vaccine. For our trial with the Sinopharm and Sinovac, we have completed the recruitment and vaccination. Majority of and that, of course, we are waiting for the interim analysis result. The bivalent vaccine from the Moderna have just been published in the New England Journal of Medicine, and again, it showed a very positive result with this bivalent vaccine, which is of BA.1 plus the wild type, the original Wuhan virus, and again, it showed a very good so-called Omicron protection in terms of neutralizing antibody, especially with the hybrid immunity. That means the previous infected group of more than 7,500 so-called neutralizing antibody titer against using just the monovalent mRNA primitive vaccine. And similarly, for no previous infection, against fare better in terms of neutralizing antibody titer against the original vaccine. Safety data is very similar between both the original vaccine, the new and the new bivalent vaccine. In a similar study, probably in Nature Medicine, with a slightly different bivalent vaccine from the same group, and showing that by 180 days, there is a slight drop in terms of antibody titer, but still very good result with the bivalent vaccine compared to the monovalent original vaccine. The antibody titer is much better in all these subvariants, especially in the Omicron subvariants. Side effects, of course, the mRNA versus inactivated vaccine is, of course, the myocarditis that is significantly worse in the or higher prevalence with the mRNA vaccine. Nevertheless, in terms of actual number, is still very low. In this study by Professor Ian Wong and myself, and of course, the BioNTech vaccine have a slightly higher risk in terms of compared to the control. In terms of the percentage of 12.5%, much higher in the male group, especially those who are between the age of 12 to 17. And the adjusted ratio is about 14 times. The reason for this perhaps is the high metabolic rate and also the lower body weight in the 12 to 17 years old group, especially among Asians compared to our Western adolescents. And that, of course, there are risks if there are intravenous vaccination has been shown in the clinical infectious disease studies that we published by Professor K.Y. Yun and myself, and showing that accidental intravenous vaccination will give rise to very severe myocarditis in this mouse model. But overall, the absolute risk is still very, very low. Bell's palsy again is higher both in the inactivated and also mRNA vaccine group, slightly higher in the inactivated vaccine group. Nevertheless, this is still very low compared to the so-called in terms of the absolute value. Just quickly touch on some new vaccine, including the aerosolized adenovirus vaccine from CanSino by Professor Chen Wei group, and of course, it's been shown very positive results in terms of the T-cell response, in terms of the antibody response, in the so-called a nobilized adenovirus vector vaccine, especially in the T-cell response. This vaccine has already been licensed to use in Shanghai population. And again, of course, we will be looking forward to seeing some clinical effectiveness data from this vaccine. Our own HKU and also mainland China collaborated intranasal vaccine, again being shown in this phase 2 study, that is able to generate a very good T-cell response, probably not so significant in terms of the IgA antibody response. The overall positive percentage is around 30%. Is probably not as good as what we expected. Nevertheless, we are still waiting for our own phase 2 result data to come out in the next few weeks. So in conclusions, looking ahead from pandemic to endemic, the stem cell and post-transplant patients have the poorest immunogenicity response, and they will benefit from the monoclonal antibody prophylaxis. Nevertheless, we are still need to, of course, we need some new antibody in order to keep up with these new subvariants emerging. In terms of antiviral treatment, again, is very, very important for early diagnosis and early antiviral treatment. Overall, the long COVID, as defined by the WHO, that means that is so-called 3 months post-symptom onset and then lasting for another 2 months, that means total 5 months, is actually relatively fewer in Hong Kong because of our early treatment compared to our Western counterparts. Criteria for moving forward, of course, is that there are widespread infection and mild disease Omicron, creating a very robust hybrid immunity with very high vaccination rate and natural infection. And we have some very effective antiviral treatment. And then, of course, we will be able to have the Omicron adaptive vaccine available for our use to increase the breadth and the boost against the Omicron and other subvariants. So the likelihood is that every winter we will still need the annual COVID-19 vaccine, and of course, very important, the flu vaccination. Face masking probably will remain in this winter, and of course, the many winters to come, especially during indoor, and that will protect us against not just COVID, but also influenza and other respiratory viral infection. And hopefully we will have the intranasal COVID-19 flu combined combo vaccine for us to use in the near future. So with this, I will like to end my talk, and I hand the stage back to Ada. Thank you very much.
Sorry for that. And the second speaker is Dr. Leong. Dr. Leong is an infectious disease physician who is in private practice in Singapore. He is passionate on education and has a strong advocate for prevention of infectious disease, especially through vaccination. Today, he is going to share his experience on COVID-19 prevention in immunocompromised patients. What else beyond vaccination? Dr. Leong, please.
Hi, this is Dr. Hoe Nam here. I'm an infectious disease physician from Singapore. I'm very, very grateful to the organizers, the Hong Kong Society of Infectious Diseases, to ask me to come to talk a little bit about COVID-19 infections and the role of a monoclonal antibody, which we know as Evusheld. I'm going to start with the lecture properly. Let's be very honest here. COVID-19 vaccines make a big difference, and it is honestly very effective. I'm here to talk about monoclonal antibodies, and I think Professor Hung is going to talk a little bit about the treatment, but truly, vaccines are very, very effective. This is old data all the way to the days of Delta, and you notice that it is really very effective in preventing severe COVID-19 infections, reducing down hospitalization, admission to ICU, and very importantly, death. And I can't ever emphasize again and again that COVID-19 vaccines are very effective, and data up to Delta is that it's 90% effective in reducing deaths. But the effectiveness stops there when the person is not fully immunocompetent, or they have other morbidities such as heart diseases, diabetes, strokes, kidneys, obesity. Obesity is a major risk factor, chronic respiratory failure, immunosuppressed, as well as chronic liver disease. So in these cases, the immunity falls. And we see it on the right, you see the numbers. We don't have the 90%, but we have closer to even 60 to 80%. The vaccine is not so good for those with chronic medical conditions. Now, if you really go into a little bit more dissection on the immunocompromising condition, you notice that the cancer patients, the hemodialysis, organ transplant, and the immunosuppressive therapies, they do worse. Okay, the antibody response falls, and the organ transplants have it worse. It is as if you had the vaccine, but many individuals do not mount an immune response. Without an immune response, the vaccine is not adequate, which means the patients, the weakest amongst us in our population, they are at greatest risk. They are at greatest risk of having COVID-19 and possibly severe COVID-19 infection. You and I have seen these patients go through COVID-19, and when one such case comes in, especially the days of Delta, we will sweat, we will worry. So the immunosuppressive therapies don't have such a good effect as well, but certainly it's not as bad as the organ transplants. So if you look at the US population, and I think the same population figures apply to Hong Kong and Singapore, is that about 3% of the adult population are severely immunocompromised. And this in turn leads to vulnerability in COVID-19. So they could have cancers, they could have chemotherapy, transplants, etc. All this putting them at risk for having bad COVID infections. And it doesn't stop there. It is disproportionate. 3% of the population, but it consumes 44% of the hospital resources. Think about it. If your hospital administrators can free up just 2% or 5% of a hospital base for you every day, you will thank God, you will thank Him, because you and I are having the same problem now. We are stuck with patients without hospital beds. We need to free up this hospital beds, and one of the targeted groups are actually those who are severely immunocompromised, who may end up with severe COVID-19. If we can prevent their infection, we prevent their hospitalization, not only are we saving lives, we are talking about saving hospital beds for someone else. How can you target this? Well, a little bit of science, a bit of basic science. I know this is a bit repetitive for you guys, but just bear with me and look at the pictures for a while. You realize that there is a receptor binding protein which will bind to the spike protein, and the receptor binding will then hook up and the virus gets integrated into the cell. And what we really want to do is to block this binding. If you can find an antibody that binds to the spike protein at the right angles, at the correct angles, and failure of binding in turn will lead to failure of infection of the cell. And this is where it shows up very nicely. You'll see that the purple antibodies here binds at the spike protein and it fails to join into the receptor and in turn prevents infection. Well, they have been hunting for monoclonal antibodies. We heard about it. We have had Regeneron, we have had Sotrovimab, and of course we have Evusheld here, who comes in the form of Tixa as well as Silga. The full name is Tixagevimab as well as Silgavimab. I'm just going to call it Tixa and Silga from now onwards. It's really quite a challenging name. So Tixa and Silga binds to the spike protein and prevents the binding of the spike protein to the receptor, making it an effective blocker. So what are the characteristics of this Tixa and Silga? Mind you, these are two monoclonal antibodies. So Tixa and Silga were first identified for people who had SARS-CoV-2 infection. So they found 2196 and they found 2130, but they didn't leave it as such. They went on next to do modifications. With the modifications, it became a little bit more potent, and certainly immediately you know that their longevity of the monoclonals, giving it a possible prophylaxis use. So Tixa and Silga underwent YTE and TM modifications, rendering it more than just a monoclonal antibodies, giving it more effectiveness compared to the other agents. So they have the YTE modification on your left, as well as the TM modification on the right. So YTE does something incredible. Increases the half-life about 4 times. It goes up easily to 100 days. We know monoclonal antibodies last about 30 days, but with this, your half-life pushes on to 3 months. In truth, it can easily last 6 months of duration of protection. Very good. One shot that lasts 6 months instead of one shot that lasts only for 1 month. The other advantage about the YTE modification is it kind of moves the monoclonal antibodies all the way to the upper tract disease, where the fight is. The fight is in the upper respiratory tract, and when you actually put the monoclonals there, you're going to bind better with the spike protein and the virus and prevent infection. The TM modification is also quite incredible because it decreases the likelihood of immunopathology. We all know when we give monoclonal antibodies or antibodies in general, there's always a risk of this unusual immunopathology. So I like it because it prolongs it, reduces down the risk. It seems like a good idea. And you guys probably realize that unlike the other monoclonal antibodies, there are 2 agents here, Tixa and Silga. It is as if instead of having a single engine plane, you actually have 2 engine planes. And if one engine doesn't work, I still have the other one that can still help fly the plane. So this is a study in a phase 1, which looked at how Tixa and Silga performs after giving the monoclonal antibodies. And immediately on the x-axis, you realize it goes for 270 days and goes for several months. So the monoclonal antibodies does last for a long time after injection. Remember, they've been modified for longer half-life. And this is just phase 1 study to show you that the monoclonal antibody stays in the system. Now, if you look at the effect of the monoclonal antibodies, you realize on its own, it is only so much. It's only a limit. And you see that in the yellow boxes and white squares, 0 and 6. But if you combine them together, there's a synergism because they will all target the spike protein. So it's like instead of just having one soldier to fight the enemy, you now have 2 soldiers to fight the enemies. You have a right hook and a left punch. You become more effective in neutralizing the virus. So when you combine the two, you actually have synergism resulting in a better response. With a better response, with a reduction in the use of monoclonal antibodies, and this is important in dose sparing. How about the potency of it? I can hear you guys asking, seriously, Dr. Leong, in terms of the antibodies, where the virus has mutated from alpha, beta, gamma, delta, and omicron. We're done to BA4 and 5, and you know Singapore has gone on to XBB, and I know XBB has gone on to Hong Kong. You guys are predicting that it will be similar to Singapore. And over at the US side, we have the BQ.1 and BQ.1.1. Will it still be effective? At this point in time, the manufacturers are still testing Evusheld against the XBB as well as BQ variants. But certainly up to BA4 and 5, it is effective. You're right. At any one point in time, the luck of the draw can change. Then change and immediately Evusheld will be no longer effective. I'm thankful that it's been effective to this date. I'm hopeful that it remains effective. So at this point in time, it integrates quite well all the way to BA4 and 5. The conclusion at this point in time, before I go on next part, is that COVID-19 vaccines are still very important, but people's immunity are poorer, becomes an issue. Tixasilga is actually 2 monoclonal antibodies. Think of it as 2 engines on a plane instead of just one, who has been modified such that it can last much, much longer. It is effective against all variants of concern after BA4 and 5. As for the rest, they are still undergoing testing. On my part, I have not seen any failures so far. That's really very good. There is an unmet need. People at high risk of COVID-19 infections, they really need a layer of protection besides vaccines. Besides the mask, besides the vaccines, you really want to have an extra layer of protection, and that's where Evusheld comes in to minimize the risk of severe COVID-19. So what's the role of the monoclonal antibodies? I'm going to show you what they plan to do for Evusheld. They really wanted to do the PROVENT study, and PROVENT is actually prevention. It's a pre-exposure prophylaxis. But they also have gone on to do the Storm Chaser, where we do use for post-exposure prevention. I've done it for my patients, and my patients who's very immunocompromised ended up, you wouldn't believe this, ended up being positive on the antigen testing, but he had no symptoms at all. The wife was infected. He was with the wife in the hospital. The wife developed COVID-19, but we gave Evusheld for the patient, and he didn't develop any symptoms at all. The antigen test came out positive. He was totally well. He cruised through it as if there was nothing at all. So they also do outpatient treatment or IM injection so as to avoid hospitalization. This is something which I haven't done, and certainly we do use it for inpatient treatment, Evusheld, where we're given it intramuscularly or intravenously. And this helps in preventing severe COVID-19 in the form of treatment. So there's PROVENT, Storm Chaser, Active 2, Active 3. But what we're really going to talk about today is PROVENT in the form of prevention of symptomatic COVID-19. So the PROVENT trial, which is a phase 3 randomized double-blinded placebo-controlled study, is actually look at the efficacy of a single dose. Single dose of Tixasilga as 2 intramuscular injections compared to placebo. And mind you, this was done way before Omicron was birthed. It was more like Alpha, Beta, and Delta. So what they did was they looked at anyone who's 18 years old and above who was at risk for getting COVID-19. Mind you, they didn't look at individuals who had vaccinations. They didn't want people who have been infected previously. This way, they actually identify individuals at greatest risk of getting COVID-19 and in turn, severe COVID-19. So they gave 1 dose of Tixasilga, 300 milligrams. The important point here is 300 milligrams because the recommendations have changed to 600 milligrams. In the trial, they only used 300 milligrams and did a randomization, and we're going to look at the inclusion criteria. So the inclusion criteria look at people who are 18 years old and above, but Singapore-wise, we've actually moved on to 12 years old and above, as long as you're 40 kilograms and above. And people who who will benefit from passive immunization with antibodies, and people who are deemed to have inadequate response to active immunization, and people who are increased risk of COVID-19 infection. Very importantly, they are medically stable individuals. Certainly, in my own clinical practice, I've given it to people who are much sicker, especially when they develop COVID-19. But of course, for this study, they only chose the medically stable individuals. So this is the trial demographics, and you look at this, you'll be quite impressed that they have quite a widespread immunosuppressive diseases, diabetes, obesity, heart diseases, cancer, COPD, etc. Now, there's a nice mix of less than 60 years old and more than 60 years old. I would prefer it if they took more of the more than 60 years old. They have a predominant white representation. Asians are there, but very, very small. We're talking about less than 3%. Looking at the numbers in terms of demographics, there you have it. You'll be surprised. But I guess this is Western population. 41.7% are deemed as obese. Okay, 41.7%. That's quite remarkable. They have adults who are more than 60 years old. You and I know that 60 years old is not really a major risk factor in the times of Omicron, but they certainly were in Delta. Chronic kidney disease, only 5%. Liver disease, about 5%. COPD, 5%. So not exactly the kind of population which I and you and yourself and myself are really targeting. We really want the immunosuppressed patients. They have it at 3.8%. So with this, they look at the age, sex, race, whites, and non-whites, ethnicity. They're kind of balanced up. Trust my word, they are quite balanced in both groups. Tixasilga versus placebo. If you look at the exclusion criteria, those are people who have an active infection with fever, those with known drug allergies, etc. Those who are on the investigational drug, those with history or confirmed SARS-CoV-2. If there's SARS-CoV-2 before, they're excluded because they really want the person to be immunocompromised. Previous hypersensitivity or pregnancy. If you look at the data here, after about 6 months follow-up, you realize that there's a massive reduction, relative risk reduction of about 80%. So simple mind here, we'll just remember overall effectiveness in the days of pre-Omicron is about 80% effective. If you look into the different groups there are, be it Asians, blacks or whites, they're all effective. The Asian cuts across 0. That's because the numbers are really, really small. You can't make any good sense of it. But in general, race is not a problem, at least not in our clinical use of the drug. So it's effective across different races and demographics. And here, where we look at the risk of whether there's coexisting conditions, obesity, hypertension, smoking, all seems to be fine. Where it crosses 0, where the relative risk reduction is not deemed adequate, a lot of it is actually because of small numbers. But obesity, hypertension, smoking, no issues at all. Now, this is actually where we look at diabetes, asthma, cardiovascular disease. It crosses 0. Trust me, it doesn't really make a big difference. Primarily, the numbers are really, really very small. On the right-hand column, you only see 1 case, 3 cases, 2 cases, 3 cases. It's not significant. The numbers are too small to make it really effective. So in general, the diabetes, asthma, etc., they work as well. Chronic kidney disease, it works. Chronic liver disease, immunosuppressive therapy, etc., all fine. My criticism is that I wish those who were infected with COVID were bigger numbers so you can see the relative risk reduction better. So if you look at this survival curve, you realize that for Tixas-Silga, having had Tixas-Silga, you have a lower risk of a RT-PCR positive symptomatic illness. So it is really quite effective. We're talking about lower risk of being PCR positive with symptomatic illnesses. That's good, which means it's proven it helps in reducing down COVID infections. And what they've gone on next to look at the Tixas-Silga levels. After 6 months of administration, you can see that the titers are still very good. At 180 days, it's still very sustained. And this is neutralizing antibody titers. And these titers, which we achieve at about 30 days, is much, much higher than those reported in convalescent sera. And this would explain to you why the convalescent sera study didn't quite work. For some individuals, they did beautifully well. For some individuals, they just didn't do well because the amount of antibodies is really inadequate. Now, this is the adverse effect side. You have to trust me that it is actually very, very well tolerated. We've given many patients with a single dose of Tixas-Silga, no major adverse effects, no serious adverse effects seen. Everything was really quite well received. We do give this in outpatient settings where no issues at all. The protocol is for intramuscular injections, but I do give it intravenously. I have an intravenous protocol for it. It is especially important when patients have low platelets, already patient has a pre-existing intravenous line, and we could just give it intravenously. Again, this is just the different kinds of adverse events there are. In general, it is very, very well tolerated, perhaps a little bit of injection site pain, and that's about it. Number of participants reading with many medical problems, no major issues with the use of Tixas-Silga. So in summary, the PROVENT-3 with their phase 3 randomized double-control parallel group placebo-control multi-center study showed that it's really quite effective for patients who are at risk for inadequate response to COVID-19 vaccine, or they are at risk for severe COVID-19. It turns out to be actually quite effective in reducing down the incidence of symptomatic COVID-19. Risk reduction of about 76%, or in my mind, 80%. And overall, this is actually effective for about up to 6 months as a 6 months follow-up. But after 6 months follow-up, you will probably need to redose again. Adverse effects are actually very mild and moderate in intensity. Majority, actually all of them are actually very well tolerated, no particular issues. And even if the person develop COVID-19, they don't end up with severe disease or critical disease in COVID-19. At this point in time, I just want to stop for the moment and just share with you that initial approving amount was actually 300 milligrams. We've gone on next to give 600 milligrams. Because of the 2 monoclonal antibodies in the twin engine plane, one of them didn't work very well. So hence, we're giving 600 milligrams now for the Evusheld instead of the usual 300 milligrams, and that's for Omicron. Now, what is NCID? NCID is the National Center for Infectious Diseases. It is the Singapore's CDC equivalent, where NCID will provide guidelines on the use of pre-exposure prophylaxis. So we do use pre-exposure prophylaxis in patients with moderate to severe immunocompromised situations where we fear that they may mount an immune response, or in the individuals who have reactions to COVID-19 as not suitable for COVID-19 vaccines, we actually give Evusheld. So I've given it to both groups, either be them having an allergic reaction to the vaccines, or they have a severe immunocompromised state. Most of the severe immunocompromised states which are used are actually the bone marrow transplant patients. They received it well, and some of them do end up with COVID later. But the COVID-19 which they have tends to be much, much milder. They end up with mild pneumonia at worst, and they snap out of it with some simple treatment. So nothing fanciful. I don't have to worry about severe COVID-19 for them. Some of the groups which fits into the immunocompromised host will include the transplant patients, cancer patients, heme cancer, other conditions that suppress the immune system, end-stage kidney disease, or advanced or untreated HIV. So they actually do define it for us, what are the different forms of treatment when we should use Evusheld. In general, NCID will tolerate whatever the ID physicians, be it myself in private practice, who gives it, as long as we can justify the reasons. Okay, that comes to the end of the talk. Well, I'm going to be around and I'm going to answer question and answers later. Feel free to ask me anything, be it politically correct or politically incorrect. So I'll see you later. Bye.
Thank you, Dr. Leong, for the very excellent talk. So now we would proceed to the discussion section. Prevention and treatment of COVID-19 for immunocompromised patients are really very challenging, as pointed out by our two speakers. On one hand, they're at risk of infections, and on the other hand, they may be difficult to treat, as well as among reduced immune response to our vaccine. So tonight, in addition to our two distinguished speakers, we are also very delighted to also have the two presidents of our co-organizing society to join as a panelist for the discussions. Apart from Dr. Maggie Ma from the Hong Kong Society of Transplantation, we also have Dr. Norman Fai from President of the Hong Kong Society of Hematology, Dr. Patrick Lau, the President of the Hong Kong Society of Medical Oncology, to join our discussion. So the audience, please feel free to type in your questions in the QA box, which is located on the right upper corner of your screen. So before we proceed to the question from our participants, may I invite our panelists to share with us their insights or experience or any challenge in the management or prevention of COVID-19 in their patients, like the hematology patients or the medical oncology patients or the patients with chronic renal disease. So may I invite Dr. Ma to share with us some insight first, followed by Dr. Patrick Lau as well as Dr. Law.
As mentioned by Professor Hong and Dr. Leong, that renal failure patient as well as organ transplantation, including the kidney transplant, they are at increased risk of a severe COVID infection. And in our observation, we also observe quite a number of patients who required hospitalization or even an intensive care service. And And similar to the data presented by Professor Hoe, we observed that those patients who receive vaccination, they're doing much well than others. Of course, we have not yet started our individual injection for our kidney transplant recipient yet, and we are waiting to observe any benefit to our patient. And I would like maybe in our subsequent Q&A section, maybe we can discuss about whether how should we stratify the risk of infection and the role of the Evusheld in organ transplantation, whether the duration of transplant matters or whether the immunosuppressant they are on really matter, because there is evidence showing that mycophenolate-based treatment, they associate with much lower antibody response. And so I wonder whether when we judge which patient who are eligible for Evusheld injection, which should be determined by the duration of transplant, or that depends on the maintenance immunosuppressant they are on. And just a question to our speakers and also the panelists for your opinion.
Thank you, Dr. Ma. We can discuss more during the Q&A section. So may I invite Dr. Patrick Lau, President of the Hong Kong Society of Medical Oncology, to share his insight with us.
Thank you, Ada. Thank you very much. I'm very happy to be here today to join the program. And thank you, Professor Ivan Hong, and also Dr. Leong from Singapore. I really enjoyed this talk and I learned a lot. For oncology patients, of course, they are immunocompromised. And having COVID infection is definitely not a good thing because they run the risk of having more severe disease as well as high mortality. So for our oncology patients, we definitely would recommend usual, proper, early immunization and vaccination, as well as timely use of antiviral in case of infection, provided these vaccination and treatments are in the optimal time, according to each patient's anti-cancer treatment accordingly. I'm very, very interested today to learn about Tixa and Silga because it is a very important strategy for oncology patients and immunocompromised patients because they have probably less B-cell response to vaccination. For oncology patients, I think Tixa and Silga is still at a relatively early study stage. I can find some literature on hematological malignancy, and it is likely that 600 milligram dose will be required. For oncology patients, I'm eagerly awaiting more study on Tixa and Silga in our immunocompromised patients who are on chemotherapy or other anti-cancer therapy. So yeah, I would like maybe Dr. Leong can elaborate a little bit more on the Evusheld in oncology patients if he's aware of more studies. Yeah, thank you very much.
Yes, Dr. Leong, would you like
to
respond?
The easiest thing to do is if you look at the spectrum of people who are at risk, the transplant and those who are immunosuppressive, those are the ones at the greatest risk. And for myself, most of my patients who actually have received them are actually transplant hosts, transplant recipients. And especially those who have just transplanted, we tend to recommend them. Those who have been transplanted out for a long time, especially the kidney transplants, etc., we may not. And very often it is the renal physicians who actually refer them into us. And how does the renal physician then stratify? Number one, many of them would actually have gone for vaccinations. They want to see if there's an antibody response, an immune response to it. We don't have a T-cell measurement, a good T-cell measurement form of testing. So many of them would actually use the NTS, the anti-spike protein antibodies, to see the response and in turn use that as a marker, as a surrogate marker for the T-cell response. If there is an antibody response, then the renal physician will tend not to worry too much. But on the other hand, we have had individuals who have actually gone for 3 mRNA vaccinations and there were no antibody response. The renal physicians will often refer them to us, and then in turn, we will offer the Tixa Silga as a prevention. So that's the easy part about the renal transplants, solid organ transplants. The bone marrow transplant patients, especially after transplants, I would routinely offer it to them and refer offer to them. And if they're willing to take it, they'll be fine. So in fact, yesterday, okay, if you haven't realized, the presentation was recorded about a week ago. Yesterday, I had one transplant patient who's just out of bone marrow transplant for about 3 to 6 months. He had an evushell just about 4 months ago. He developed COVID because he got it from his lovely wife. His wife was infected, passed it on to him. He developed a little bit of a cough, a little bit of fever just for 1 day and recovered subsequently. So in fact, his friends were amazed how is a person who is 62 years old, gone through bone marrow transplant, still less than 6 months out of it, had a much milder symptoms compared to them. So he was really quite grateful that he had evushell. He broke through. Honestly, it's a breakthrough infection, but what he was going through was really a very, very mild disease compared to anybody else of his age or anybody else with a bone marrow transplant. So that's in terms of the transplant individuals for solid organ as well as hematological transplant patients. For those who have been out of bone marrow transplant for a year or even more than 6 months, we'll try to do vaccinations and we'll try to get the vaccinations up as quickly as possible. For the oncology patient, then it becomes really a mixed bag because the kind of drugs which are used by oncologists are of different kinds of immunosuppressants. And again and again, I really want vaccinations as number one choice. So in terms of oncology support and oncology requests for evushell, we do have patients being put up forward for evushell, and the oncologists are the ones who actually advise that I think his drugs are really quite immunosuppressive, he's quite ill. The kind of people which I would really push up the ranks, okay, let's be very honest. AstraZeneca will want every oncology patient to receive it. But I'm going to be very honest here and tell you, we could actually try to stratify some of them. Number one, we know that age is a significant risk factor, especially if you are more than 65, 70 years old. Number two, we know the diabetics and those with ischemic heart disease and bypass surgeries, they are really at high risk. So if a person who's going through oncology treatment, together with additional risk factors such as heart problems, diabetes, chronic renal failure, he will go right there at the top of my list, as these are the people I would really want to use evushell on. But on the other hand, if we have with a person who is vaccinated, especially with 3 shots of mRNA vaccines, who develop malignancy and is young at 40 to 50 years old, he may not really benefit from evushell or Tixasilga, as we call it. So I guess we really need to stratify further. Again, AstraZeneca would like every oncology patient to do it, but I don't think we really need to give it for every oncology patient. Stratify them by age, comorbidities, and the kind of immunosuppressants they are, and perhaps the risk of exposure epidemiologically for the individual. I hope that answers part of the question at least.
Well, that's really very useful, not just fulfilling the criteria, the list out criteria, but also further stratify according to each patient's clinical condition. Just a very quick follow-up question on that. And Dr. Leong has also mentioned that we use 600 milligram instead of 300 milligram given the Omicron, as well as in some patients we will use the anti-S T cell response as a surrogate marker to use the combination therapy. So Ivan, what is your view on our usual practice in our locality? Yes. And
I think I could supplement what Dr. Leong has been saying. Important to know is that evushell, like vaccination, is not protecting against infection. You can still be infected, but the most important thing is that it will protect you against severe disease and mortality. Especially in those who are immunocompromised. Within the transplant group, in fact, in Hong Kong, we have already started vaccinating using evushell in about 200 patients who has undergone stem cell transplant. A few of them have been on B-cell depleting agents. So we follow up these patients for about 3 months, and quite remarkable, of course, they all have very good response, and they're able to maintain a very good antibody level even after 3 months. So that's first thing. With the 150 milligrams dosage, the lower dosage. Okay, so with the in terms of the within the transplant group, I think the most vulnerable are those who are undergone the stem cell transplant, who basically have zero response to 3 or 4 doses of vaccination. The second group, of course, is what Maggie is saying is the renal transplant patient. And of course, those who are on the mycophenolate tends to do worse in terms of the number of immunosuppressants you are on. So the larger number of, or the high dosage, or the larger number of immunosuppressants you're on, the worse in terms of the antibody outcome. So these are the highly indicated group. The liver transplant, on the other hand, tends to do quite well in terms of vaccination. So I'm also a gastroenterologist, so I've been seeing liver transplant patient, and also those who are on liver transplant. Those tends to do very well in terms of antibody response. Heart lung transplant patient, again, similar to renal transplant, they are again quite vulnerable and tends to have lower antibody response. Within the so-called the immunocompromised group or the oncology patient, perhaps the worst group is the B-cell, those who are on B-cell depleting agents. Those who are on lymphoma, they are B-cell depleting agent, anti-CD20. They tend to have, again, very poor antibody response, and they tend to again, they will benefit from the Evusheld injection compared to others who are on other chemotherapy or also on those who are on biologics. In our patients who are inflammatory bowel disease on Crohn's ulcerative colitis, they tend to do very well in terms of antibody response to vaccination. So these groups perhaps is lower priority compared to those who are on B-cell depleting agents. The 300 versus the 600 milligrams, I think the 600 milligrams will benefit against the Omicron subvariants, especially against the BA.2.75, against the BA.4, BA.5, and also the new subvariants, the XBB or the BQ1 or the BF7, because of the body weight. But in general, Asians tends to do better because we are so-called smaller in size compared to the Western counterparts, so the Western population. So again, 600 milligrams will be beneficial, but probably more in those who are relatively big in size in terms of against the subvariants. So I will also support using the high dose. Nevertheless, we still need basically a new monoclonal antibodies. If you look at the bertuzumab, that tends to so-called have a lower resistance right now against the subvariants. So we probably need to consider introducing the bertuzumab. Again, I think AstraZeneca is preparing some newer monoclonal antibodies targeting against the new subvariants. So again, I think we need those new monoclonal antibodies quite soon with this rate of subvariants emerging, especially among the post-transplant group.
Yeah, that would be very important because with the emergence of the new variants, that if we know that AstraZeneca is already developing some target towards that, that would be very good news. So we have some questions from the audience. So Dr. Ma, would you like to start some questions from the audience for our speakers?
Yes, and the first question is directed to Dr. Leong and asking about the Singapore experience about the Evusheld administration for pre-exposure prophylaxis. And is there any specific patient criteria for getting the administration in Singapore?
Yes. Okay. So the individual must be shown to be immunocompromised, and there is a definition for it in terms of could it be a transplant recipient on other forms of immunosuppressive agents, and all those have been defined quite clearly as in what dosing, etc. Or the other indication is for individuals who have reactions to vaccines, who cannot tolerate a vaccine. There has been approved for indication. I've used it for someone recently in a form of post-exposure prophylaxis, whose wife again was infected, and it turned out he didn't fall sick at all. So those are two main indications. There are certain guidelines as to what drugs you're using and what dose. I could send them to you if you want to.
May I have a follow-up question about the Singapore experience? Is the Evusheld funded by the government or the patient paid by themselves?
A great question. If you are Singaporean or you have a right of residence in Singapore and you have gone through your vaccination series, this is a carrot and a stick thing. The stick is that if you don't complete your vaccination series, you have to pay everything upfront. But if you're Singaporean or you have right of residence and you've gone through a vaccination and if you need the medications are free. But if you are a foreigner or you didn't complete your required vaccination, then you will have to pay for it. So it is really six big ones. Six big ones in Singapore dollars is 6,000 Singapore dollars. If you multiply that out, I think it's about 8 times of Hong Kong dollars. It's really a lot of money. Okay, so right, but mostly it is free for Singaporeans and PRs, mostly free.
Oh, I see. So it sounds quite reasonable to me, huh? Just personally, but well,
Ada.
Yeah, I would like to ask Dr.
Yes.
Law. Yeah.
It's because I have received a question from my hematology colleague Joyce about our hematology patients. I want to ask two experts, Ivan and also Dr. Leung. Since some of our patients have multiple thrombocytopenia, they may not be able to receive an intramuscular injection of the vaccine. Any comments on the intravenous protocol for our hematology patient with multiple thrombocytopenia? I totally agree with our two speakers about the risk stratifications and also the benefits for our hematology patients, particularly those being given B-cell depleted agents. We have experiences of loss of some lymphoma patients in the fifth outbreak in Hong Kong due to the profound COVID-19 infections. They are unable to clear the virus after multiple courses of antiviral treatments. So any comments on the intravenous protocol for our hematology patient? Thank you.
Very, very interesting. We are seeing quite a number in Queen Mary Hospital, up to 20 patients or more, who are becoming a chronic carrier of the COVID-19. They have been basically refractory to all treatment, with the Paxlovid or with the Molnupiravir or combo or Remdesivir, whatever you give, or even Avashel as a therapeutic. They fail to respond. So we are thinking of other ways of treating them, but we will hopefully be able to tell you, what to do in a few months' time. We're doing a trial on that. But interesting is that for those who receive the Avashel, we'll still be able to give it intramuscularly, even though with a thrombocytopenia. We just have to basically press on the injection site for a little bit longer after giving the injection. So we have no problem in stem cell transplant patient or thrombocytopenic patient giving the injection in the buttock. So it is something that is not to worry, giving it intramuscularly.
Yes, thank you.
Okay, I'll just follow up very quickly on this. I do have the protocol for the intravenous infusion. It has been used in trials with AstraZeneca, but it is not officially published. You can contact me. You can find my name on the internet as well as my email. I'll be glad to share the protocol with you. Yes, I just, for many of these patients, they have the existing PICC. It doesn't make sense to do the injections. Now, Professor Hung is most correct to say that we do have individuals, the very immunocompromised hosts, who end up in this chronic state. But thankfully, for most of our patients, we will just actually go on for intravenous remdesivir for a long course, and we do check on them to make sure that the virus is eradicated totally. Yes, we are totally worried and terrified of this chronic infection, and from there, the next variant, the next Omicron that will come up from there.
Yes. Thank you very much. Thank you.
Thank you, Dr. Leung. So Jocelyn, you can contact Dr. Leung for the IV protocol. We have one question from Dr. Michael Wong. It's about the PROVENT study, which excluded patients with previous vaccinations. So Dr. Wong would like to ask our speaker any data or experience on the effectiveness of Evusheld on immunosuppressed patient who has previous COVID-19 vaccination.
Specifically in this question, previous infection, the efficacy, I think the efficacy would be as good as what the publications are saying, if not slightly better because of the previous infection. I believe that the previous infection will offer some form of immunity, not perfect in terms of the B cell, and certainly not perfect in terms of the T cell. but it does offer a layer of protection, and with the Evusheld on top, I don't see that to be a problem. If the person has vaccinations, even though if it was an inactivated vaccines, as seen with 3 doses with infection previously, plus an Evusheld, we are really quite confident that he should be able to do quite well, unless his immunity is right in the pits. Otherwise, I think he should be able to cope quite well.
So,
So
Dr. Ma, would you like to continue?
Yeah, there's another question to Professor Hong about the intradermal vaccination. Because in influenza vaccine, it seems that intradermal vaccination will initiate better immunogenicity and immune response. And so how about the intradermal administration of COVID-19 vaccine? Do it do any good to a patient? And will we consider intradermal vaccination for immunocompromised patient in order to achieve a higher antibody response?
Yes, we just completed our intradermal vaccination trial on our post-transplant patients, which we've been doing on both renal, liver, and also on some patients who are on biologics. And it seems that the intradermal vaccination group do better than the intramuscular vaccine group. We have yet to have the final analysis, but it's definitely very safe. And in terms of antibody response, it's fair better than the intramuscular group. Nevertheless, as I've said, in those who have been on B-cell depleting agents or those who are on stem cell transplant, intradermal vaccination perhaps is not as good, I would say. Even though we have not actually do a comparison of giving a Evusheld injection for those group, because those group are even with intradermal vaccination is still very difficult to overcome the so-called immunocompromised states. But for those who are on perhaps on biologics, on other chemotherapy, on some of them, especially in the liver transplant group, then the intradermal vaccination tends to do better than the intramuscular group. Okay,
could I just jump in here very, very quickly? I have a patient who actually had B-cell depleting therapy, rituximab. He's a lymphoma patient. He actually went through 4 doses of mRNA vaccines. And thereafter that, with the 4 mRNA, there was no antibody response. Now, we did it as using a trial looking at the T-cell response. His T-cell response was actually very comparable. In fact, on the higher range of the mRNA, in normal individuals with the mRNA response. So this patient eventually developed COVID-19. He developed COVID-19 and I had to handhold him. I handhold him and say, look, you have COVID-19 now, it's confirmed. Do you want to number one, actually before that he was offered Evusheld, he declined. He declined it, he was a foreigner, he just wanted to rough it out. Number 2, when he developed COVID-19, I offered Paxlovid to him, he declined. He says, my symptoms are really very mild, I just want to rough it out and see what happened. So he roughed it out at about day 3 to day 4, he recovered totally with a 0 antibody response. And Professor Hung said it again, it is actually about preventing infections. So he got infected, but his T cell was able to hold it such that eventually by the day 5 to day 7, he was quite asymptomatic without any antibody response, but we know he had a good T cell response. And thereafter, about 1-2 months later, I checked his NTS again. Of course, he had 0 NTS, and that's expected because of the B-cell depleting regimen. Thank you.
Thank you so much. In the interest of time, although we still have some questions, but I think we may try to send the questions to the speakers, and then if there is available email address that we can try to answer the question and send back to our participant. So we'd like to conclude tonight's symposium, and thank you all participants who have participated amongst the Typhoon number 8 evening with us. And thank you very much for the 2 very distinguished speakers on the sharing of those very fruitful and useful information, as well as our panelists, Dr. Patrick Lau and Dr. Lorman Fay, on the fruitful discussion. And last but not the least, also we would like to thank our sponsor, AstraZeneca, for their generous support to support this symposium. I'm sure you all have enjoyed the evening as much as I do. So hope to see you again very soon. We are also going to organize and continues to organize lots of academic symposium to share the latest update on infectious disease with all of you. So have a great evening and see you all later on. Thank you. Bye-bye.